Hello, hi, I'm Dr. Najra. I'm an obstetrician and gynecologist currently practicing in Johor, Malaysia. And today I would like to talk about obesity and pregnancy. Whenever we're discussing about any diseases in pregnancy, it is also advisable to have a look at how the disease will affect during the pre-pregnancy period as well as the postpartum period. But today, my focus will be on obesity and pregnancy period, where we are going to discuss about the care of pregnant women who are living with obesity. We're going to address gestational weight gain and also have a look at care of pregnant women who had bariatric surgery. Why is it important for us to talk about obesity in pregnancy? Well, there's a lot of complications that can be associated with obesity in pregnancy, and mainly we're looking at the risk to the mother. This would include gestational diabetes mellitus or GDM, preeclampsia, women who has higher weight are at higher risk of miscarriages, as well as VTE. We know that VTE or venous thromboembolism has been one of the major main cause of maternal mortality in Malaysia for many years. Apart from that, obesity also put women at risk of cesarean birth, and women who has higher weight are also at risk of depression as well as anxiety. Obesity not only affect the mother, but it could also affect the baby, where they are at higher risk of congenital anomalies, prematurity, neonatal death, and stillbirth. And baby are also at higher risk of being microsomia or LGA or large for gestational age, where we know this could lead to birth trauma, not only to the mother, but also to babies, such as shoulder dystocia. Babies who are born to mother who has obesity are at risk of getting obesity themselves at later age, as well as they are at higher risk of metabolic disorders such as cardiovascular disease, as well as higher risk of diabetes mellitus later in life. How can we use BMI in pregnant women? Well, we know that Malaysia, as part of Asian country, do adopt a lower baseline BMI to consider someone to have obesity. So it's the same thing with our woman. So BMI of 27.5 can be considered to have obesity, and further assessments are needed to make the diagnosis of obesity, and those with BMI of 23 are considered to be having overweight. And BMI is applicable up to 18 weeks of gestation. So it is important for us to make sure that women have their height and their weight measured at first antenatal care. And subsequently, we need to monitor the weight throughout the antenatal period, emphasizing on looking or monitoring the gestational weight gain. And how much weight do we allow women to have? So it should be based on the pre-pregnancy BMI. And if they are overweight, if they are underweight with BMI of less than 18.5, so we can allow them to have about 12.5 to about 18 kilogram throughout the antenatal period. If they have a normal BMI, so it's about 11.5 to about 16 kilogram. And if they're overweight, we're talking about allowing them to have up to 12 kilogram of weight gain. And if they have obesity, then we need to consider having a lower total weight gain, about 5 to 9 kilogram. So this is based on the recommendations based on IOM in 2009. So how do we address the nutritional intake for pregnant women with obesity? I think it's important for us to address folic acid, because folic acid have known to reduce the risk of neural tube defect or NTD, and we know very well that women who are planning for pregnancy needs to take at least 0.4 milligram of folic acid. But women who has obesity will require a higher dose of about 5 milligrams daily whenever they're planning for pregnancy, and it needs to be taken at least 1 month before pregnancy. And vitamin D3, 1,000 to 2,000 units daily is recommended throughout the pregnancy, and if possible to be taken during the pre-pregnancy period as well. And we need to also address other micronutrients deficiencies, including iron, because we know Malaysian women are quite at higher risk of having iron deficiency anemia. And do a full nutritional assessment, including not only the micronutrients, but also the macronutrients intake, including the fiber intake, as well as the dairy intake and protein intake of the woman. If problems are identified, early referral to nutritionists or dietitians are recommended. We can use the FIGO nutrition checklist for pre-pregnant and early pregnant women to assess whether women are getting enough nutrition to support their pregnancy. And if we look at this, they do have recommendations or what are the micronutrients that need to be considered or need to be supplemented if they are unable to achieve that with their diets. And as I said again, in Malaysia, iron, we need to address iron deficiency early on in the pregnancy as well. And physical activity do plays a role, not only in maintaining gestational weight gain, but also it could help reduction in the postpartum weight of women, especially those with higher weight or higher BMI. And it could also help to improve the psychological well-being of the woman, especially during the postpartum period. We need to consider physical activity that are safe and acceptable for the woman. There has not been found to be a specific modality for women with pregnancy. Any kind of physical activity, any form of movement is actually beneficial for them. And we need to also take into consideration of the cultural aspect. And now we're talking about the specific antenatal care for women with obesity. So what are the assessments that needs to be done when a woman has a higher BMI or higher weight? So we need to monitor the blood pressure, making sure that the suitable cuff size are used because the woman's at high risk of preeclampsia. And we can also try to reduce the risk by offering aspirin when woman has obesity and other additional risk factor. And GDM, we need to check for GTT early on in a pregnancy and repeat it again at about 26 to 28 weeks if it was normal during the first time. And scan is important to monitor the baby size because the SFH or symphysis fundal height is not going to be accurate in women who has obesity or sometimes even in women with overweight. And greater surveillance of fetal movement in third trimester need to be emphasized as women with obesity are having a higher risk of IUD. Assessment of mental health, look for depression, look for anxiety, and for those with BMI of more than 40, it is recommended to have an anesthetist referral during the antenatal period in order to help with the intrapartum planning. And what can be done to help women to achieve a healthy gestational weight gain? So first of all, we need to assist women in identifying what are the enablers and barriers in order to achieve a healthy gestational weight gain, and advice for nutrition and physical activity. They will require regular follow-ups, more compared to those with lower risk, and referral to appropriate providers should be considered early in pregnancy. And how to approach the gestational weight gain, we can consider using the 5 A's, where first we would ask for permission to discuss the weight and weight gain during pregnancy, and then we assess what are the potential root cause and obesity-related risks specific to that woman that we assessing, and advise on the importance of gestational weight gain, its risk, its related complications, and what are the management options that can be considered. And after that, we have to agree on realistic plan to achieve the health outcome and assist in women to identify the barriers, the facilitators of what can contribute to an unhealthy gestational weight gain, and educate appropriate uh, and consider appropriate referral and follow-up for the woman. So what are the specific intrapartum care that can be considered for women with obesity? So we can actually consider induction of labor at term because of the risk of IUD. So we need to discuss this with obstetrician and the woman themselves, whether it is acceptable for the woman to have an induction of labor at term. And appropriate IV access is important, where it is recommended that whenever a woman goes into active phase of labor, they would have at least 2 large bore pranula and electronic fetal monitoring or CTG and fetal scalp monitoring may be helpful for us to monitor the fetal well-being during the intrapartum period. In women who are going for normal or vaginal delivery, early placement of epidural catheter is going to be really helpful because in case of emergency cesarean section, we can, in our best, try to avoid general anesthesia. In relation to prophylactic antibiotic, women with obesity may require a higher dose, and antibiotic could help to reduce with the postpartum infection as well. They will require active management of third stage of labor because of the higher risk of PPH, and VTE prophylaxis need to be considered not only those who underwent emergencies or elective cesarean section, but also those with high BMI who had a normal delivery. And now we're going to talk about the specific antenatal care for women who had bariatric surgery. It is important for us to know what type of bariatric surgery that the woman had before pregnancy, whether it's restrictive or malabsorptive, because we know that women with malabsorptive bariatric surgery are going to have a higher risk during the pregnancy. And it is important for them to avoid pregnancy during the first 12 to 18 months post-procedure because of the risk of IUGR and the risk of macro and micronutrients deficiencies that going to cause problem to the baby as well as to the mother. However, the bariatric surgery or women who had bariatric surgery do have a lower risk of GDM and preeclampsia. And as addressed earlier, they are also at higher risk of SGA or IUGR as well as congenital anomaly, mainly associated with the malabsorption and rapid weight loss. So it is important for us to make sure that they were on effective contraception because we do not want to get pregnant during the first 12 to 18 months post-procedure. And it is very, very important for us to look for micronutrient deficiencies. They may need a higher dose of multivitamins. We're talking about iron, folic acid, thiamine, the vitamin A, E, and K, zinc, copper, and selenium. And vitamin A, we should also be careful not to exceed the recommended dosage. Folic acid, even though they have lost their weight, they still need a higher dose, about 5 milligrams per day. And calcium intake needs to be addressed and supplemented if they're not able to reach the daily recommendations. Vitamin D, if they are known to have deficiency, they may need a higher dose of up to 3,000 units per day. And vitamin B12 is important as well. They may need a higher dose to achieve a normal serum level. Most women who are pregnant are not aware of the risk of obesity to the pregnancy. So it is important for us to keep educating and provide continuous support to them so that we can help them to reduce the risk of obstetric complications. Multidisciplinary approach needs to be considered. We need to get the help of nutritionists or dietitians as well as physiotherapists so that the issue of nutrition and physical activity can be addressed appropriately. We need to discuss and continue to support women to achieve healthy gestational weight gain. They will require more frequent monitoring to compared to women who doesn't have obesity or compared to women with a lower risk, and specific actions need to be taken when they have obesity as well as other risk factors associated with a pregnancy. And with that, I end my presentation today. And if any questions, you can ask and we will try to address the issue appropriately. Thank you.